to focus on innovations in radiotherapy for lung cancer and how those are hopefully improving clinical outcomes as well as quality of life for our patients. Here are my disclosures. A little bit outlined. I don't know how much time you spend listening to radiation oncology lectures, so I'll just give you guys some of the basics about radiation for lung cancer and then get into a few topics that I think are particularly relevant. One regarding patient-generated health data, and then about the idea of personalizing and perhaps de-intensifying our lung cancer treatment. So just in general, radiotherapy is a very commonly used treatment modality for any cancer, especially lung cancer. 50 to 60% of all cancer patients end up receiving radiotherapy at some point through their journey. For some patients with localized disease, radiotherapy may be the only treatment they need. For patients generally with more locally advanced disease, radiation is often combined with systemic therapy, surgery, or both. And then for patients with more advanced and diffuse disease, radiation can play a big role in providing palliative therapy. So what is radiation? And this is not meant to be a physics lecture, but it is involved in what we do. So I'll give you guys a little bit of a primer. So radiation in general just refers to any kind of energy traveling through any medium. When we talk about radiotherapy for cancers, we generally are talking about ionizing radiation, which has enough power to generate ions, and those ions within the patient or within the tumor are what exert the biologic effect. Now, the most important biologic effect of radiotherapy is that radiation can hydrolyze water molecules into hydroxy radicals, and those can cause DNA damage. And when DNA damage happens on both strands of the DNA molecule, you end up with a double-stranded DNA break, which may or may not be repaired. But that's sort of the effect that radiation has, is by damaging the DNA of cancer cells so that when they try to multiply, they're sabotaged and instead they perish. So radiation can be created and delivered to patients in several ways. The classic way to do this is using a radioactive element. So a radioactive element is one that has a natural decay, and that decay could be giving off X-rays, or what we call gamma rays, or some kind of particles. And here you can just see a few historical pictures. And the one in the middle actually is an early version of what we call the gamma knife, which you may have heard that term. It's still a device that we use, although now it looks a lot fancier. The gamma knife is a good example of how radioactive elements can be used to deliver very modern and precise radiotherapy. In that situation, it's generally for patients with tumors in the brain. The patient is positioned such that the tumor is located at the focal point of about 200 little holes that are all pointing to a certain space, which is where the tumor is. That whole device is then placed inside essentially a box of radioactive cobalt. And all the X-rays that can get through the patient are only the ones that are directed through those holes right to the tumor. So that's a way of giving radiosurgery using a fairly old technology. More often these days, radiation is generated using a linear accelerator. That's a machine where a high or electricity, say from the wall, is used to generate or to accelerate electrons across a voltage. Those electrons hit a target, and then that gives X-rays as a result. They can be targeted and shaped towards the patient's tumor. The linear accelerator is a classic, what we call a C-arm linear accelerator, is pictured on the left. That can rotate and spin around the patient. On the right is a fancier, if you will, version, something like a cyberknife, where the whole linear accelerator head is on a robotic mount, which can move around the patient and treat from an even larger variety of angles. Another term you'll hear often is proton therapy. Proton radiotherapy is very similar to X-ray radiotherapy, except the energy is delivered with protons, not with X-rays. And because protons have some mass, the protons, once they get to the tumor, they kind of just stop. So if you're treating the patient from the front, this tissue behind the tumor will get no dose at all. So that can be really advantageous in giving even more conformal or focused radiotherapy in appropriate settings. This is a picture here actually of the New York Proton Center. We have a nice collaboration in the New York City region between my hospital, Mount Sinai, and Sloan Kettering, where we can all treat these patients with proton radiotherapy when we think it's important. Here's just a schematic of what that center looks like. The takeaway is just that a proton radiotherapy center typically is quite large. The one we have in New York is basically a whole city block. So when you compare that to how easy it is to build a proton center versus a typical center that uses photons or X-rays, it's sort of order of magnitude higher. So the costs are quite large. The space needed is a lot. So at this point, there's only about 25 proton centers in the country compared to the hundreds or thousands of facilities with linear accelerators generating X-rays. One term you'll hear a lot is gray. Gray is the most commonly used these days unit to measure radiation. Previously, we used terms like centigrade and rad and sieverts and other things, but gray is pretty much what we use these days. To put things into context, a typical dose that might be used to try and treat and cure lung cancer may be 50 or 60 or 70 gray, whereas for palliative purposes, we often use lower doses like 8 gray or 10 gray or 20 gray. So radiotherapy, like any treatment, can cause side effects, but I'll say perhaps unlike some systemic therapies, the side effects we expect from a given radiotherapy course are very much specific to the patient's anatomy and exactly what part of the body will be targeted with radiation. Here I've pasted some language actually from a consent form from one of our clinical trials talking about some general possible side effects of thoracic radiation for lung cancer. The first one they mention is irritation of the esophagus or esophagitis, which can cause trouble swallowing. There's generalized fatigue. There could be skin changes, dermatitis. There could be inflammation or scarring of the lung that could affect breathing. There could be irritation of the heart or a risk of increased risk of heart disease years and decades later. And then some rarer things like issues with the spinal cord or ribs. But again, I'll say when you see this language and hear about a patient's experience with radiation, it's very much an individualized journey. So as just an example, here are two patients I've treated on a clinical trial. Both patients had stage 1 lung cancer and were treated with very focused or stereotactic radiotherapy. I've circled the tumors for you guys in blue. And when I met these patients and told them about the risks of the radiation, we had very different discussions. For this patient, we spoke about a risk of the radiation damaging the ribs, which could cause fractures that we see on CT, and they can cause pain. Whereas this patient here on the right did not really have that risk, but this patient's tumor happens to be very close to the esophagus. So the biggest concern was for irritation of the esophagus, which could manifest as dysphagia or even stricture. So both of these patients years later have been cured. I selected these cases because they unfortunately did have those toxicities we were worried about. But just as an example that whatever you read or hear about radiation should not be generalized across patients. It's really very much specific to the anatomy. So just some general use cases, so to speak, for radiotherapy in lung cancer. Patients with early stage disease historically have been treated with surgical resection. There we now have the option of treating with stereotactic radiation, which I think yields very similar outcomes. We've had some randomized trials comparing surgery and stereotactic radiation that have failed to accrue, but we do have at least one that seems like it will make it to the finish line. Here's some of those smaller studies that never finished accrual. But this is the VALOR study being run by Drew Moganaki from the VA system. This will enroll about 700 patients with stage 1 non-small cell lung cancer, and they'll be randomized to either surgical resection or stereotactic radiotherapy. So I think within a few years from now, we'll have an answer. I suspect cure rates are quite similar between the two based on all the previous evidence, but this study I think will do a lot to tell us if surgery should remain the default treatment option for these patients, or if it's really appropriate to, even for patients who have both options and are expected to have minimal side effects with either option, if they should be able, if it's really up to them and there's no difference in the cancer control rates. Locally advanced non-small cell lung cancer, typically we consider that to be stage 2 or 3 disease. For this, there are a few different treatment options. I would say I'll mention the two sort of current most favored options based on recent trial results. One is treating with curative intent definitive thoracic radiotherapy. Typically, that's a longer course of radiation, which could be given daily over approximately 6 weeks. And that's usually given with some chemotherapy during the radiation course and often with immunotherapy or targeted therapy afterwards based on some recent trials. The other popular option these days is to go for surgical therapy. And now, based on some recent trials, patients are usually treated with chemotherapy and immunotherapy first, and then may go on to get surgery and potentially additional immunotherapy. We don't have recent studies comparing the effectiveness of these two approaches. I think radiation is an option for almost anybody, where surgery is limited perhaps to patients with good heart function and lung function and disease that can be removed safely. So if you just look at survival rates among patients who have surgery and don't have surgery, they will favor patients who have surgery. That being said, I think in most cases, both treatments will yield similar cure rates, and it really comes down to having a nuanced multidisciplinary discussion and really understanding what is the patient's functional status, what are the patient's preferences, and which side effects is the patient willing to risk. And finally, for more advanced disease, radiotherapy plays a role. Radiotherapy could be given using very simple techniques to, fairly quickly and effectively. But more often these days, we use stereotactic or very focused radiotherapy, sort of mimicking what our surgeons might do if they were to take out a tumor. And these are often delivered in just 1 or 3 or 5 treatments. On the left, you can see some images from cranial radiosurgery cases. In the middle, you see some liver SBRT, and on the right, some spine SBRT. So radiation does, play, I think, a fairly important role in patients with more advanced disease, certainly to address pain and other symptoms, to prevent skeletal fractures and spinal cord compression. In some settings where the biology of the disease is such that there's limited metastases and systemic therapy is working effectively to prevent new metastases from developing, some patients can be treated with radiotherapy for metastatic disease with the intent of prolonging life. So now move on to a few sort of more nuanced topics centered a little bit around research that I've been doing as well as others around the country and world. The first topic is patient-generated health data, which is a term that encompasses really a few different things. So this triangle here represents sort of my view of how we can assess our patients. On the bottom is the clinical data. That's what physicians, I think, are looking at most often and most used to looking at. This is things in notes, labs, images, pathology reports. This is the stuff we get in our EMR, and then this is what we're thinking about most of the time, for better or for worse. But there are other dimensions of data that I think are important, and we're recognizing that they're important more and more so. One is patient-reported outcomes, which is similar, almost, largely overlapping with quality of life. And more we're realizing that the patient's experience, the symptoms they report, are more important than what we think the patients are experiencing, and actually can do a lot more to tell us how that patient is destined to do with regards to future complications, future disease control, and even survival expectations. The third side of the triangle, I would say, is data that we could collect now from wearable devices and other devices, sort of leveraging modern technology to collect some metrics that we previously didn't have. Things like step counts, things like heart rates and pulse oximetry done at home, sleep metrics, heart rate variability, body composition changes, all things that we're not used to looking at routinely, but I think that should change. So in my view of what we're doing now, as physicians, we're certainly looking at the clinical data. In some settings, we're getting some patient-reported outcomes, some cancer centers more than others, some disease sites more than others. But most of us are really not looking at data from wearable devices yet. But I do believe wearable devices will play a big role in the future. Some pros to the wearable device data: it can be objective, dynamic, multidimensional. Data can often be collected passively. Data can be collected between clinic visits. Instead of seeing a patient for a few minutes every week or two, we could be learning something about their functional status and their physiologic status continually. Some potential cons: there are some extra hurdles to collecting this data. Monitoring the data is challenging, and we frankly don't even know what to do with a lot of this data. And if some alarming metrics are observed, somebody needs to respond to that, and those workflows are not in place in most clinics. And the benefits of this, as opposed to our standard means of monitoring patients, are just not yet proven. Here's how I think wearables can improve cancer care. Before treatment, I believe simple metrics such as step counts might help us understand a patient's functional fitness and which patients are likely to do well with aggressive treatment versus perhaps benefit from more de-intensified treatment. During treatment, and this is where I've done a lot of my work, I think wearable devices can give us a ton of information about how patients are tolerating treatment, what's going on between those clinic visits, and what we can do to better support patients during aggressive treatment. And then after treatment, for people who've completed treatment and hopefully will be long-term survivors, it's helpful to promote healthy lifestyles. And for patients, or any patients, even if their disease may not be under control, data from step counts and other biometrics can help us notice when there's declines or late toxicities or even early signs of disease progression. I'll point out one high-profile study that you may have heard about. This was presented at ASCO this year and is in the New England Journal of Medicine. This was a randomized trial looking at aggressive structured exercise intervention for patients who've received surgery and chemotherapy for colon cancer. And not only did the exercise improve patients' fitness and quality of life, it actually led to a pretty dramatic survival benefit from reducing the recurrence rate of these colon cancer somehow. So that's a very exciting finding and one that I think appropriately got a lot of attention. Most of my work, again, is focused on what's happening during treatment and how we can get our patients through the treatments where there's often complications leading to interruptions. But anyway, you do this, I think we hope to improve clinical outcomes and reduce healthcare expenditures, which should all improve the quality and the value of the care we provide. So to that end, we've led a number of trials over the last decade or so here at Montefiore Einstein using wearable devices. Here's a list of them. Many of them, as you can see highlighted in red, heavily involve lung cancer patients. Most of them, since these have been led through our department, involve patients getting radiotherapy, but we have also run studies for patients solely getting systemic therapy like chemotherapy, immunotherapy. Many of these studies were looking at specifically the feasibility of data collection or how we could leverage data collection to help patients reduce hospitalization rates. In recent years, we've also been incorporating wearable devices into our therapeutic clinical trials as a nice way to show that the treatments we're offering are well tolerated. Our strategy has been to try and be inclusive. I know many patients are able and like to function using a lot of tech, and some patients are not so interested. So we chose to use a simple device. For most of our trials, we've been using what's called a Garmin VivoFit, pictured here. It's a simple wrist-worn pedometer. It shows you the time. It shows you the step count. That's really about all it does. It uses a watch battery and can last over a year. There's no charging. And we had some detectors in our clinic, so anytime a patient would come check in for their radiotherapy treatment, the data would be downloaded passively. Also, it was waterproof. Patients could sleep with it, and it was not that expensive. So if a patient lost it, we could easily replace it without any issue. Just some highlights from our first study. This was a study with about 40 patients getting radiation and chemotherapy for either lung, head, neck, or GI cancers. You can see on the right what we call a spaghetti plot, which admittedly looks a little bit crazy, but this is the data we get. So each line here is a patient's step counts over time, reference to the day they started radiation. And the triangles actually denote hospitalization events. So about a third of our patients were hospitalized during chemo and radiation. And you can see that those hospitalizations are kind of clustered towards the bottom. So essentially, if a patient is walking more than 5, 8, 10,000 steps per day in the last few days, there's very little risk of them ending up in the hospital anytime soon. Whereas if the step counts get down, especially down to the 2,000, 1,000 range, that indicates something is not going well, and that patient probably needs more attention. And when running the analyses, the model came out to a nearly 40% reduction in hospitalization risk for every 1,000 steps taken each day. So a very powerful effect, even in the small pilot study. We found similar results in our next few studies. This is a pooled analysis of our first 200 patients or so from 3 studies. You can see it was, again, a mixture of head and neck, lung, and GI cancer patients mostly. And most patients were getting chemo and radiation as definitive treatment. On the right is admittedly another crazy figure. This is a scatter plot. Each dot represents one patient. The y-axis is a step count average before the patient started radiation. And on the x-axis is age. So one thing you notice is that step counts decline with age, and that's a very well-known phenomenon, so much so that we were able to actually take normal volunteer data from some large databases to find sort of what we think should be the 25th percentile and the 75th percentile of the step count as a function of age for people without cancer. So that helps us understand that it's natural for step counts to go down with time, and also gave us a frame of reference to say, okay, are our patients who have a cancer diagnosis, and often there's some comorbidities involved as well, are they relatively active or inactive? And the answer was many of them are inactive. We found that about half of our patients fall below the 25th percentile of an age-adjusted step count expectation. The scatter plot here, we did code things based on performance status. So performance status 0 is supposed to mean asymptomatic, doing everything you would normally be doing without disease. Performance status 1 is supposed to be mildly symptomatic. Performance status 2 is supposed to be symptomatic, but still up and about more than half the time. But what you can see here is that there's patients who are essentially not walking at all, almost bedbound, it would seem, who have performance status of 0, 1, or 2, which essentially means that we as clinicians do a very bad job of assigning performance status. I think if when we see the patients, we spend hopefully half an hour with them, we read the history, we get to know them more over time. I still think we sometimes don't really have a great sense of what's going on in the patients, with the patients between visits, how functional they are they ever leaving the apartment or leaving the house. So I think this was really eye-opening to see that just how different the step counts are from what you might expect based on the performance status. We published one analysis looking specifically at the lung cancer patients. So it was about 50 patients, and we noticed that the step count average or the activity level based on that 25th percentile before the patient even starts treatment was a very powerful prognostic factor. So here's some Kaplan-Meier curves just showing the spread. Patients who are inactive have a much higher risk of hospitalization during chemo and radiation and much worse expectations regarding progression-free survival and even overall survival duration. So this, I think, suggests that if more people were collecting this data routinely, we would learn that probably this ECOG performance status should just be replaced by some kind of objective step count metric or other physical function metric. So what can we do about this? So in addition to looking at the step counts before treatment, as I mentioned, we were looking at step counts during treatment and found that patients who are inactive in recent days are more likely to be hospitalized. This was an analysis we collaborated with a team at UCSF with expertise in machine learning and artificial intelligence, and they ran some nuanced models indicating essentially, this is called an ROC curve. Basically, the higher the curve is, the better. And basically what they found is if you want to train a model or have a model perform in predicting hospitalization events, and you gave that model only clinical data, it doesn't really do much. And that's the things like performance status, weight, age. Basically, it follows this diagonal line, which means it's just random chance. But if you give it step count information, suddenly your model performs very well. And if you have step count information and clinical information, the clinical information is not adding much. Basically saying that if you're following a patient's step counts, you have a very good chance of predicting upcoming hospitalization events, and perhaps that gives us a window to intervene. So to that end, we do have other studies looking to help patients through chemo and radiation. This is one nice study by the same group, or the same PI at least, who helped us with the previous analysis. He ran a very simple randomized trial where if you take patients at high risk for hospitalization, if you just see them more often in the clinic, that reduces the hospitalization risk. So it's standard during radiotherapy for us to see patients once a week, plus as needed. So I see all my patients in this clinic on Wednesdays, and certainly if there's any symptoms anytime, they can ask the nurse to be seen or tell the nurse, and then they'll call me and I'll see the patient. But maybe that's not enough. And maybe if we knew which patients were at high risk, such as based on step counts, we should see those patients just twice a week or 3 times a week. And that simple intervention, at least in this randomized study, did reduce the risk of hospitalization by about 50%. So we collaborated actually to design this prospective randomized trial that was looking to prove this, that if you take patients getting chemo and radiation for lung cancer, and you give half of them a wearable device, and you follow their step counts, and if needed, see them more often, will that help reduce hospitalization events and reduce treatment delays? So this study we actually proposed and it was approved, but it was just around the time of COVID hitting and hit some snags in relation to COVID. And then afterwards, due to some funding issues from the specific funding source we had. So we never got to finish this study, but we are looking at different avenues to rekindle this study. And I think, and I hope this could be something that shows positive results and really transforms the way we follow our patients through these aggressive treatments. So just to sum up what I've learned from our trials with wearable devices, at least in my practice, almost all patients will accept the idea of wearing a device if we're giving it to them for free, and if we're not requiring them to interact with the device app very much. Some patients are just not interested, but most people will accept it, especially in that acute phase of receiving treatment when everyone's worried appropriately about the side effects of that treatment. We found daily step counts are an incredibly powerful metric, and it's something we have most people can at least put into context. We've also looked at different things like how fast people are walking or bursts of activity versus long periods of inactivity, and really daily step counts is all you need, at least based on our analyses. And daily step counts is new information in the clinic. You cannot predict it based on age, performance status, or anything else. We now have some more recent and ongoing studies using fancier devices that actually give us a lot more information about sleep, recovery, blood pressure, pulse ox, heart rate variability. So I suspect this is just the tip of the iceberg, but I think it's important that we start to learn how to study this data and bring it into our clinical practice. And as you can imagine, with so many cancer patients, so many cancers, so many metrics, so many types of devices, different treatments, there could be hundreds or thousands of studies one could design that could help us learn how to better assess our patients. And in the future, I do hope that we're looking at all sides of that triangle equally so. So then the third topic will be, again, centered around some studies we've been leading here at Montefiore about treatment personalization and treatment de-intensification. So immunotherapy, we know, is a very effective treatment for many patients with lung cancer. There's a biomarker we have. It's not perfect, but it's the best we have so far, called PD-L1 expression. And for patients with high PD-L1 expression in their tumor, we've seen from studies for advanced or metastatic disease that immunotherapy is more effective than chemotherapy, causes fewer high-grade adverse events, and improves quality of life. And this has been seen in many big studies. So with that in mind, we ran a trial actually looking to bring immunotherapy into the treatment of stage 2 and 3 non-small cell lung cancer patients. And being that immunotherapy works so much better than chemotherapy, we actually designed a study that removed chemotherapy from the treatment paradigm for patients with high PD-L1 expression. So this is a study we ran called SPRINT. Patients with high PD-L1 expression were treated with induction immunotherapy with a drug called pembrolizumab, 3 infusions over 9 weeks. And then they had some restaging imaging, and often we saw a response, a shrinkage of the tumor and lymph nodes. We used a PET scan to help us quantify that response. And then based on the PET findings, we delivered just a 4-week course of radiation, shorter than the standard 6-week course, and actually with lower radiotherapy doses for the tumors and lymph nodes that were small after receiving after being treated with immunotherapy. Patients then went on to receive additional immunotherapy to complete a 1-year treatment course. Patients with lower PD-L1 expression were treated with standard chemo and radiation, typically followed by adjuvant immunotherapy. Here's just a little schematic of our risk-adapted radiation approach. Here's a patient where after the immunotherapy, there was still a fairly sizable lung tumor, and that was treated with sort of the full dose of radiation in yellow, whereas some small lymph nodes that nearly disappeared were treated with a much lower dose of radiation to help minimize side effects while still hopefully taking care of any microscopic cells that were left behind. So here's some initial study results. First on the left, we can see the adverse events scored by physicians. And you can see generally the rates of high-grade adverse events were low and sort of what we might expect. Patients getting the standard radiation and chemo had some maybe more esophagitis, whereas patients getting immunotherapy, there were a few cases of immune-related adverse events like arthritis or colitis. If you ask the patients how they're doing based on the pro-CTCA or the patient-reported outcome, even with this limited sample size, we already saw differences in about half of the symptoms we asked about. So this, I think, is a great example of how when you ask the patient how they're feeling, you get answers that are very different from if you ask the physician, how is the patient feeling? And if you have a change in treatment, you're probably more likely to notice the difference in side effects if you ask the patients as opposed to if you ask the physician. So even with the small sample size, we demonstrated that if you drop the chemotherapy and you reduce the radiation doses, you lead to fewer side effects. Here are the clinical outcomes, and even though it's not a fair comparison necessarily because of the different PD-L1 expression, certainly the progression-free survival and overall survival outcomes for this high-risk population when they were treated with the novel chemotherapy-free SPRINT approach exceeded our expectations and what we've seen in historical controls, which is justified, I believe. some follow-up studies that we have ongoing that have recently activated. But in general, this approach of treating patients with chemo-free treatment, which is, really going against what has been done in the last few decades, I think it has, a few aspects that I think will sort of take this at some point, I think will become a more standard way of doing things. We start by using induction therapy. And for patients with high PD-L1 expression, that can just be immunotherapy without chemotherapy. That gives us a very early and powerful signal of, is the treatment working? And perhaps if it's not working, something needs to be changed. And if it's working well, then we can move on and give the radiation into smaller volumes with lower doses, causing less side effects. This also gives us a window to study new drugs. So the study we did with Sprint was pembrolizumab, which is already well established for a non-small cell lung cancer. But now we have studies using different immunotherapy combinations. Some drugs from AstraZeneca, monalizumab, oleclumab, as well as from Regeneron with fianlimab, which are alternate immune checkpoint inhibitors. And now, just by giving this induction therapy and quantifying the response on PET, after just a couple months, we can really see which of these regimens is working most effectively in the most patients. Also, this makes sure that everybody gets a chance at receiving immunotherapy. We know that if we start with chemo and radiation, about a quarter of patients will never get to immunotherapy due to toxicities or early disease progression, which for somebody with high PD-L1 expression, I think is really, that's missing out on perhaps the most effective treatment. So by rearranging things, I think we can sort of get things in the right priority. There's also data that immunotherapy works best before radiation, not during radiation, and works best when the tumor is still there. There have been 2 large randomized trials for patients with melanoma where they got immunotherapy either after surgery or before surgery and after surgery with the same drugs on both arms. Both studies showed dramatic reductions in the recurrence rate if you give a few cycles of immunotherapy before the surgery. I think the same will be true for radiation. The immunotherapy sort of is trained by the tumor that's in situ, and that's how the immune system gets trained to fight the cancer. In the case of radiation, if we give immunotherapy and shrink the tumor, we end up with smaller targets, lower doses, and that I think will reduce toxicity rates, improve patient-reported outcomes, and actually reduce immunosuppression, which is a factor with radiotherapy, which could make the immunotherapy even more effective.